Welcome to Mastering and Guideline in Ultrasound and Echo.
Hi everyone. For many reasons, I decided to prepare this topic in two parts. Part one will be public; everybody can access to that. But part two is only for member group. And because of technical problem, part two will be uploaded tonight or maximum tomorrow. Enjoy it. Hi everyone. Let's have some brainstorming with such question. Why sound wave should be perpendicular to the jet for VC? Is not against the physics principle of the sound. If it is perpendicular, the Doppler shift will be zero and it shouldn't get any color. Why we see color in those situations and why perpendicular? What's going on? This amount of Elysian velocity which change the baseline is effect for our measurement for PISA and finally mitral regurgitation grading or not? How? Each of them is better in which situation, where we use each of them. How to optimize our image that perform those technique correctly and result will be reliable. What is the correct technique for each of them? That is another. And finally, what about the T? What we have to consider in T? Let's find the answer to all of them. Let's first see what is the anatomy of mitral regurgitation color Doppler. In any closed fluid system, here heart, when the blood wants to pass through an orifice, narrow area, it creates a specific pattern and shape that can be appreciated by color Doppler, and it has specific component and characteristic component that we can appreciate in all kind of the regurgitation and even stenosis, shunt, and so on. Almost the mechanism is the same. The component of the jet will be proximal to the orifice, a circular shape that it come and result of convergence of the blood flow from the pushing the blood through the left ventricle to that area. When blood converges more and closer to the orifice, it finally at a specific moment and distance of orifice, it shape a circular in 2D and spherical in the 3D shape. The size of that we called it head of the jet or flow convergence zone or PISA, that stand for proximal isovelocity area, depending of the force of the left ventricle, the amount of the blood, the size of the orifice, the compliance of the here left atrium, the pressure of the left atrium, and the size of the length of the coaptation. The size of the PISA or flow convergence zone depending all those stuff, and beside of that your setup on the color scale and aliasing velocity. That on PISA I am going to go to detail about that, just a general speaking. If you go beyond the little farther than circular shape of the orifice, it become more elliptical. If we go closer to the orifice beyond the circular shape, it become more flattening. Later we talk how it cause and what is effect on our measurement. Here we have head or PISA. Then beyond that PISA, that almost correspond below right away after orifice is neck of the jet, that in a specific spot it is narrower than the diameter of the orifice. As you can see here, this is orifice of the at the level of the orifice, and it is the narrowest part of the neck that we called it vena contracta. The canal of the coaptation or orifice has some role for creating this narrowing. It acts like the lens that dependent of the size of and length of and shape of the orifice canal or coaptation length and shape, the size of the neck and the size of the vena contracta will be different. That I'm going to talk on the vena contracta separately. After neck, we have jet area. I want to here again one more time emphasize, because we are dealing with that problem. The blood flow pattern in the heart, especially in those areas of the orifice, jet, or stenosis, anything, we have two types of the pattern, at micro level and macro level. At micro level, we have a turbulent blood flow in everywhere, at the here, there. But in macro level, we will have laminar or radial velocity. At the PISA, we have radial velocity or direction, not velocity, direction. At the neck, we have laminar, almost plug pattern of the blood flow. And at the jet area body, we have turbulence pattern. And beyond those jet area, we have eddy flow. And another things that I want to mention, if we measure orifice area of the mitral valve here, based on the diameter in 2-3 way, and evaluate the orifice area, and we measure the effective regurgitant orifice area by the VC, the result on the by technique of VC will be 15 to 20% less than the orifice area of the mitral valve. In another word, the same concept I say, that this orifice and especially canal act as a lens and make it a little narrower at the end of the neck. Now let's go first start with the jet area and how we evaluate mitral regurgitation based on the jet area. One of the easiest technique for grading mitral regurgitation is jet area method. Even though this is very easy and you can do it in a few seconds, but unfortunately in many situations is not reliable, and we have to keep those situation and condition and bring those in our conclusion. This is just only fastest way to get it, is that severe or not, is mild. For any quantitative, we have to use other technique. There are many reasons that is not reliable. First of all, the jet area dependent of the machine and software. The sensitivity and capability of each machine, even the same machine, different software, completely different. So keep in your mind which machine you are using. Second is setup. Setup is affect a lot on the jet area. First of all is frame rate. Frame rate dependent two factors. One, depth, and another sector width. For those purpose, we use usually zoom mode. That is the easiest one, but you can use sector width narrow. Is the same result with the zoom using zoom mode, but there is only differences. Both of them will give you the same frame rate, but on the zoom mode it gives you higher resolution. For example, when we have depth here at 17 centimeter, if you sector with this size and all the way from the probe to the bottom, and then we use zoom, the frame rate doesn't change, but resolution on zoom mode increased. The next one is frequency. frequency, higher frequency, better resolution, more accurate jet area. The next one is scale. Generally speaking, when you are using color Doppler, always you have to use the scale or PRF at that level and depth of the study, and know the flow velocity on that specific spot. For the big, all those valve like the mitral valve, aortic valve, scale should be around 50 to 60, depending. For adult I'm talking. For pediatric we go 70 to 80, and again depending of the depth and your machine and frequency. So we have to keep in your mind, increasing scale or PRF decrease the jet area, decreasing scale increase jet area. So there is relationship, opposite or reverse relationship between the scale or PRF and jet area. Another is wall filter. Wall filter with increasing too much is eliminate some real jet. If it's too much low, it add up to the jet area. For the regurgitation, usually wall filter for those valve should be around moderate to high. And the next and most important part is color gain. The color gain way we set up is this technique, as I mentioned in another lecture. You crank up and increase gain until blooming starts show up here. You can see a spot goes beyond the area. This should be blood, and other tissue shouldn't have any color. When you blooming, then decrease until blooming disappear. That is the best technique for setting up of color gain. Usually color gain around 50 to 60% will be the best optimizing of color gain. After setup, the next important part is the amount of preload, afterload, and the function of the LV. Increasing preload is get effect the same as increasing contractility of the heart. So in both situations, the jet area increase. If opposite way, if the ejection fraction, for example, myocardial infarction dropped, you shouldn't expect to see very huge jet, even maybe there are significant MR. So, and afterload the same. For example, high blood pressure, it increase if the left LV function is normal, is increase contractility of the heart, and beside of that, pushing blood goes the other side, that is MR or AS. If you have AS, it increase the jet area unproportional to the real MR. The next one is LA size and pressure. In acute MR, because the LA doesn't have enough compliance, so the pressure really goes high very fast. So the blood jet area dropped. Or other opposite way, when we have enlargement of the left atrium, in the chronic situation, the jet will be more correspond to the real MR, the amount of the MR. So keep in your mind, compliance, LA pressure, LA size, and function of the left ventricle, and out, afterload, preload, all of them affect on the jet area. And the last one, jet direction. Generally speaking, jet area guessing is only good for the when we have a central jet. In eccentric jets, because of the quanta effect, the jet area always be lower than real should be. For grading jet on the MR, we have two techniques. One of them is just eyeball guessing, another is measuring the jet area to the LA area. For that purpose, We go in two view, apical 4 and apical 3. Then we trace aliasing part of the jet, not all the jet, just this part that has aliased. As you can see here, this part is turbulence and aliased, not this part. Then we trace the LA the same way we do on the plaques, or apical 3 is better. Apical 3, then the ratio. If the ratio of the jet area to the LA area is less than 20%, is mild. If it's between 20 to 40%, is moderate. If over 40%, especially 50%, is severe. Just remember, you can even guess with eyeball guessing. You don't need even measure it. But again, don't forget this technique only in a specific situation with considering the other parameter that I talked a few minutes ago. For those eccentric jet that we have a lot, we don't judge based on the color jet area, but still you can guess how much will be, is that the MR severe or not. Usually we're wrapping in the significant MR in eccentric, we can see a wrapping around color flow at the other side of the jet, as you can see here or here. You can see this wrapping around. When you see this pattern, usually is at least moderate to close to the severe MR. As I mentioned, when the blood pushed through the orifice, the layer of the blood flow converge and they become closer to each other and velocity increased. At a specific distance of the orifice, the pattern shape of the blood flow become elliptical, and when we come closer to the orifice, it becomes shape and a semicircular shape. This semicircular shape is our flow convergence area, or PISA, proximal isovelocity area, and we measure the radius of this semicircular blood flow pattern on the proximal of the orifice. If we go more closer to the orifice, the blood flow pattern become more flat. Now let's see how we do it in echo. For getting PISA and measurement, after we got our image zoom mode and optimizing color, image, everything, then we start dropping our baseline on color scale slowly down until the first circular aliasing show up. That moment will be our aliasing velocity. Just remember, the shape of the PISA dependent of the aliasing velocity. If aliasing velocity is close to the zero baseline, means high, the shape of the PISA will be more elliptical. At a specific spot is almost become circular or hemicircular, or more accurate, oceanoid. And if velocity decrease too much, like here, it become more flat. So we optimizing our baseline aliasing velocity to the level that become almost a circular shape and give us first aliasing. And when we say aliasing, mean the color changing from the yellow to the blue, the first aliasing. Just remember, in the reality, in the color Doppler doesn't measure velocity. It catch relative velocity, not accurate velocity. And in reality, in action, the shape of the real pizza with the mathematical or theoretical pizza will be a little different. In theory, the pizza should be semicircular or hemicircular, but in reality it will not be circular. It will be partially circular, means a circular that at the base is flat. And studies show that this shape is more closer to the reality and 3D echo PISA. So keep in your mind, and we don't measure radius, just we measure from the base to the border. This will be your correct measurement. And another important issue is the dynamic of the regurgitation. You know, the regurgitation, the amount of regurgitation is dependent of the contraction of the left ventricle and closing force of the left ventricle to the orifice. At early the systolic and late systolic, closing force is lower, and so increase the PISA size at these two spots. At the mid become less, and based on the original recommendation, they say that we measure at the mid systolic for PISA. But study by Dr. Buck or Buck, B-U-C-K, sorry for mispronunciation, show that mid-systolic measurement will be underestimated. He studied compared with the gold standard CMR, cardiac magnetic resonance imaging. It showed that if we measure at the mid-systolic, it will be underestimated. The best technique for solving this problem is that we measure at the both and get average of them, or we use M-mode PISA that still is under research. Now let's see another tips that I want to give you here. Here are some examples for measurement. First, you go find the main circular or semicircular or oceanoid shape of PISA, like this one. You can see this will be your PISA. Then measure from the flat base to the border, or this one the same. The main is this one, so flat to the border and so on.